So some of this came from our previous work, which showed that leukemic stem cells, they're more metabolically active than their normal counterparts, and they have a dependence on mitochondrial metabolism. And we see like quite a lot of things are different in these cells, but this has been driven by BCR-ABL. It's a very potent oncogene. So what we wanted to find out was what happens when you add in tyrosine kinase inhibition, because that's always pretty much going to happen. So are the things that we see that are metabolically different, do they still matter when you have treatment? Maybe they're gone and you might try and target something that doesn't exist. So what we did was we looked at what was maybe different between a CML and normal cell to begin with. What are the biggest differences? Looking at expression of different genes, looking at levels of metabolites, and trying to see where are these different metabolites being made from. Are they coming from glucose? Are they coming from fatty acids? And then we took this forward and we looked at what changes exist when you add in tyrosine kinase inhibition, and are there any new changes maybe induced, or are the big differences you saw before, do they still exist? And then we kind of prioritized our kind of findings. We ended up kind of focusing in on glucose metabolism, and specifically a certain part of glucose metabolism where it gets metabolized to pyruvate, and it goes by a route that allows it to add in additional carbons into the TCA cycle. And this process is known as anaplerosis, and it's important in that when you look at the TCA cycle, it can be used to make things like nucleotides, and for those kind of processes you're taking out 4 carbons, and the classical route into the TCA cycle is via acetyl-CoA. That's only adding in 2. So these kind of things are important to help us as this cycle maybe be sustainable. And also when you start maybe putting pressure on with tyrosine kinase inhibition, we see that maybe certain sources like glucose and glutamine start contributing maybe a bit less. So this residual activity can maybe help the cells persist. And we kind of use this approach in vitro and in vivo. Well, I suppose the first thing is, is some of these processes that you see may be high in CML stem cells, could be high in other tissues or in other organs. But for one thing we notice is maybe fatty acid oxidation, that the leukemic stem cells do this at quite a high rate. But it actually, we also see this is also a substantial contribution in normal hematopoietic stem cells. And when you look at maybe the inhibitors maybe available to target fatty acid oxidation, they're probably not that great. Their clinical record isn't fantastic. So you've got maybe 2 strikes there that there's not a huge difference between CML and normal, and the inhibitors aren't great. So from our kind of data, we saw that the biggest differences in this case were between CML and normal was glucose. Glucose getting into the TCA cycle was definitely much higher in CML, and when you put in tyrosine kinase inhibition, there was still something there worth targeting. So there is, several options that have been maybe explored in similar cancers. In AML, they've looked at blocking glutamine getting into the TCA cycle. That's also kind of been looked into. It's probably an area of research, ongoing research in CML. So I guess when you look at these pathways, you look at what's maybe different. And I suppose it's really easy when there's some drugs that like we use have been in clinical trials for other conditions, and some of them have been phase 2 or phase 3. So when you've got a lot of data on their safety profile and how tolerable they are, that's a major de-risking step compared to if you're using maybe a tool compound and you're hoping to improve upon that. It's kind of, for us, we kind of try and use if we can repurpose something, that's like definitely our preference.